Cassidy Tsay. I am the Regional Medical Director of Blue Shield of California. I don't know, I'm not senior. I've only been here for 2 months. I used to be the Medical Director for Greater Newport Physicians. So my region for Blue Shield is Southern California, Northern area. So I think a lot of the groups here, I'm actually your Regional Medical Director. So if I haven't met with you yet, please feel free to contact me. I'll leave a stack of my business cards so actually we can kind of do more of a meet and greet. So GMP and I, we are absolutely touched by the Right Care initiative to ask us to talk about the active diabetes program. I am actually personally touched that the staff actually want me to present along with them since I'm no longer their medical director. So you're going to see throughout this presentation that the dedication and the love that went into creating our program. We are very proud of this program. I am very proud of the team. And you're going to have a chance to meet a few of these team members. So, push down. Okay. Just like our program, our presentation is going to take a team approach. So I'm going to talk a little bit more about the process behind our vision. Dr. Andrea DeCoro, our pharmacy director, will speak more about how we got there, and as well as the trials and tribulations. Dr. Christine March and Segal Phillipson, they are our hearts and soul of this program, and each of them will highlight what they do best. Basically, take care of the needs of our patients, the families, and also our physicians. And last but not least, you will hear from two of our patients who've been through this program and still part of our program, Pastor Whitfield and Margot Bennett. Before I start, I kind of want to take a poll of the audience, and the question is, diabetes account for what percentage of healthcare? So vote now, or push the button. Is it A, 21%? B, 14%, C, 5%, or D, 30%? I promise I will not hum the song. Oh, it should be. Is it working? Do I hit the down button again? Yes. That's it? So I just hit the down button?
We all got it.
Okay.
Okay, good. Thank you.
So the audience basically believe, but 64% of you guys believe that healthcare costs is 30% of the health costs. So before we go answer that question, I kind of want to ask, why do we concentrate on diabetes? It's because over 29 million people in the United States actually have diabetes, and 8.1 million of them actually are undiagnosed. So diabetes affects the entire healthcare system, but also affects the entire body, from the eyes to the heart to the kidneys, circulation system. You hear about blindness and amputation because it actually affects everything. And actually only accounts for about 14% of the total healthcare costs, but this doesn't take into account the indirect costs to the United States workforce, because there are absenteeism, loss of productivity, multiple visits to the doctor's office. That is not accounted for. So that's one of the reasons we also decided to choose for diabetes, because it's a very treatable condition. Unfortunately, diabetes does take a toll on everyone. Routines and diets have to be changed and modified. Some people may need to be on medication and some may be on insulin. Sugars need to be monitored routinely, and all these affect the patients deeply. We also recognize that physicians can't do it all. In order to effectively take care of diabetic patients, the physicians not only have to be physicians, subspecialists, as in being a nephrologist taking care of the kidney, cardiologist taking care of the heart, dermatology taking care of the skin, but also have to be a pharmacist, have to be a nutritionist, dietitian, psychologist, and also social worker. We recognize not one person can do it well and actually can do it all. It's actually not fair for that person. So therefore, we decided that the active program really should take a team approach. So our team member, Our team member includes everybody that actually has an impact and actually can make the patient better. One of the most important team members that we realize is the patient and also the families. Without their buy-in, we fail. And this is really simple. We really need the buy-in of our patient and our family. The vision for our team is really simple. First is really help our patients identify any barriers. Second, to be supportive in all aspects. It also means emotional as well as medical and physical. And most importantly, to create a care plan that is individualized to the patient's and the family's needs. There is no one plan fits all with this program. The team approach really allows everybody to do what they do best. And that's, I think, why this program has been so successful. So just having a great vision is not enough. We need a lot of support and a little bit of luck. So Hoag Hospital actually has a very good and great diabetes program for the pregnant population. And they're actually looking to expand it for the general population diabetes. And also at the time, lucky for us, Blue Shield was offering grants to many organizations that actually have programs or plans to basically provide better care for their patient population. So for us, during the winter of 2011, our active diabetes program was born. And it is now my pleasure to introduce you to Dr. Andrew DeCoral, who is going to talk to you a little and give you a little story behind how we developed this program. Andrew?
So after the great news of being awarded a grant, began the real work of putting the program together. And as I stand before you, I'll tell you that we definitely ran into our share of challenges along the way, some of which we'll share with you today in hopes that you will learn from some of our missteps. We had recently come off the success of building 2 other programs. And so for the most part, we thought this new program was going to be similar, but we learned over and over again that it wasn't. And it was different in terms of patient recruitment, and it was different in terms of physician recruitment. So originally, the intent of the program was to help establish long-term diabetic patients with A1Cs greater than 9 to better control their diabetes. But over time, the program grew to include not only established patients, but those newly diagnosed and those with A1Cs greater than 8. So in terms of recruitment, we believed that we could simply ask IT for a list of patients using the IHA criteria of an A1C of greater than 9, or patient had a diagnosis of diabetes with no recent A1C in the past year. Well, that turned out to be quite challenging since many of those patients that didn't have a lab recently obtained labs, and they were in fact in good control. The other issue is that from the time we ran the original report to the time we began recruiting, those patients also came into good control. So we started out with a huge list of like 5,000 patients, and at the end of the day, it was more like 500. And I'm sharing that with you because if we had just identified patients with an A1C greater than 9 with recent lab results, maybe within the last 3 to 5 months, that would have saved us a whole lot of time and energy. Patient recruitment initially started from the clinic rather than the personal primary care physician. Although the PCPs were abundantly aware of the new program, they weren't asked to enroll patients at that time because we thought it would be easier if we did that for them. And we reached out to patients directly with either a phone call. It started with a letter, and then if they didn't respond to the letter, then it was followed up with a phone call. So we thought it would be an easier way to bring patients in, but in reality, they didn't know who we were. We weren't the primary care physician, and so that didn't work very well at all. So, sorry. There we go. So So it was back to the drawing board, and fortunately we had done a small demonstration pilot with one of our larger physician offices, and that pilot had shown very promising results. And it was with that data and a few more examples that we were able to share with a larger audience of 130 primary care physicians. Data that was compelling enough to line them up at the end of the presentation with referrals in hand. As you all know, diabetes care is the bread and butter of primary care. And our challenge was to acknowledge that usual care works wonderfully most of the time, but our program was really designed for the rest of the population that would benefit greatly from the individualized team-based approach. And aside from PCPs, we also somehow needed to convince the endocrinologists that we were here to work with them. And that actually turned out to be more of a one-on-one approach. And as we stand here today, it is still sometimes a challenge, but it has greatly improved. And last but certainly not least is the physician's office staff. And so time must be spent up front educating the office staff. And we learned that lesson the hard way. So the last thing that you want is to finally convince a PCP to try the program and then have the office staff say to the patient, "I've never heard of that program." Okay, so now we are ready for another polling question. And so this is really to get a gauge of what types of programs are offered within your particular facility. So what type of program / care does your facility provide for diabetic patients? So A, standard of care, which would be the primary care physician and endocrinologist. B, diabetes group education classes. C, online resources, handouts, and so on. D, multidisciplinary team approach, which is what our program is. And E, other. I know we had 29 last time. I only see 20. 22. I lost somebody to the... Wait another sec. Okay, closing the poll. Oh, look at that, 54%. Use a multidisciplinary team approach. It's great. So I have shared some of what our not to do lessons were, but I wanted to be clear on the steps that we should have taken. Number one is we should have engaged the physicians and their staff well in advance of opening the clinic. We should have created a seamless referral process to make doing the right thing easy. And we also should have spent more time or researched better or even conducted patient focus groups to understand how to best encourage or entice patients to participate and experience this new type of program. In terms of what we did well, we put together a team specifically designed with the skills to address that population. We didn't take any shortcuts. And we agreed it was okay to fail in some areas, but do so quickly and then regroup. And so, as you will see, the result of the program speaks volumes. So make sure you track your data so you can also reach out to the right listeners. And with that, I will now turn over the presentation to Dr. Christy March and Segal Phillipson, who are the backbone of the program and who have made the improbable a reality.
Thank you, Dr. DeCoro. I'm really excited to be here today talking about our program. The past couple of presentations that I've given over the past 2 or 3 years since we started have been about convincing and that this program will work. And so I'm happy to be up here actually presenting the results today and having our patients here as well to talk about their experience. So as I said, we're now in year 3 of our program and the challenges of the startup are behind us. So I'm going to be talking more about the design of our program, the patient experience, and also share some results today as well. So we've designed our active diabetes program as a comprehensive care plan that provides individualized management through a multidisciplinary team approach. So to give you an idea of how that looks like, when we call the patient for their first appointment, we explain to them that they need to allow for 2 hours. And during that time, they're going to be seen by a clinical pharmacist for medication management and review. They're going to meet with their social worker to go over any overwhelming life issues or psychosocial stressors and barriers. They'll meet with our dietitian to talk about meal plans, and also our nurse practitioner who does the foot care, exams, and retinal screenings and referrals as needed based on the results of those exams. And we do market our program. We want it to be an extension of the services and a support to the physicians and specialists that are already involved managing the patient. The unique components of our program are the multidisciplinary team approach. So this really allows us to give the patient an access to a wide variety of healthcare providers and really hone in and focus on what that patient needs according to their specific needs. We work with the patient on goal setting. We want them to be empowered to manage diabetes on their own. And part of that process is setting goals that they can accomplish. And that gives them the confidence that they can really do this. And then after the initial visit, we design follow-up, again, according to what the patient's needs are. We have some patients who are commercial patients working full-time. They may not be able to come back into the clinic on a weekly basis. So we tailor the appointments in that case, maybe by phone or email. And of course, we do have phone follow-up back in the clinic as well. And as far as our communication to the PCPs and the specialists, we do that mostly through chart documentation in our EMR, which is NextGen. And when we go through and do medication reconciliation, we update the patient's medication list as well. So if the PCP or the specialist is using our EMR, they can actually see those updates in real time. And of course, there's always times when it's more urgent situation or we just really feel it's more important for us to pick up the phone and call those providers involved in the patient care, and we do that as necessary as well. So as you heard, initially our program was designed for patients with A1C of 9 or above, and then we had popular demand and we expanded that for patients with A1C greater than 8. And the majority of our patients are type 2. We do have a small subset of type 1 as well. And we, as you have also heard, have some more recent requests for patients with more newly diagnosed or newer onset versus long-standing diabetes, because the physicians are realizing really the importance of getting those patients that may run into obstacles further down the line to kind of prevent that from happening by teaching them self-management and getting them in our program from the get-go. We have found that our patients under the care of endocrinologists can also benefit from having our program, being part of our program as well. We do have kind of a little bit more of a luxury of spending more time with the patient to uncover some of those life issues or stressors or just, issues that are coming up that are preventing them. That with a specialist, and they've commented that they found those contributions really helpful in the management of their patients. I have this cartoon to kind of emphasize the importance of patient education. And it may seem, it's exaggerated, but, these barriers of, teaching the patient how to monitor their sugar and even uncovering, if they are monitoring their sugar, do they know why? These barriers aren't always obvious. So, little interventions like getting the patient the right glucometer, making sure that it's covered by their plan, that they're not going to have this huge copay when they go to the pharmacy. Those are simple things that, we work with the patient, and they really help kind of start that process of self-care. So who will benefit most from the type of interventions that we're doing at Active? We describe good candidates as patients needing more individualized education on diet and exercise, patients with a long-standing A1C that's elevated, patients that may have barriers to monitoring their sugar and injecting insulin. This could be due to fear of needles, seeing blood, or just, general misunderstanding about why they're using medications. Patients that may have overwhelming life issues that may not be, again, obvious, or they may not have communicated to anyone or to their providers. And patients with medication issues, this could be due to cost, copay issues, side effects with medications, general misunderstanding of how and when and why to take their medication. So if patients are falling into these categories, or there's a suspicion that there's something behind the scenes going on, we do encourage our PCPs to maybe consider referring their patients to active first before just immediate referral to endocrinology. Sometimes we can kind of work through these barriers and issues and spend that time, and they may not end up needing that referral. And as you have heard in the initial learnings, we have found that the highest show rate for our program happens when the PCP has that conversation with the patient and explains to them the importance of attending our program. We simplified our referral process by making it easy for the office staff and the physician to refer through our internal website, which is Access Express. And we do ask the PCPs and office staff to please educate the patient on the importance of our program and kind of give them the nudge to make that first phone call to make the appointment themselves. It's kind of the first step in the patient taking care of themselves. Because we do use our internal website, we can keep track of the referrals, and we run weekly reports and to see who's been referred. And if we find that the patient hasn't called, we reach out to them and make sure that we do our best to get them in, just so no referrals and no patients fall through the cracks. So with the diagnosis of diabetes can come fear. There's a lot of emphasis initially on, you hear about all the bad things that can happen and the negative outcomes. And if you don't do this and this, then this is going to happen to you and you're going to be on dialysis or lose a limb. So patients they come with these fears. And our goal is really to give them the tools to help manage and let them know that if you do this and if you can, we can work with you so that those things won't happen. And in that regard, I'd like to kind of give an example of how that process works in our clinic with these next couple slides that illustrate an example of one of our patients. So this particular patient was a 75-year-old male who came to us with an A1C of 12.5 that had actually been increasing from 11 over the past couple months. And he had a history of non-adherence with medications, basically just couldn't remember to take his medication. That's kind of what he told us. He had frequent urination as a result of his sugars running so high all the time. And he had been seen by a urologist who prescribed Vesicare, which is a drug for overactive bladder. So he's on additional medication for that side effect, which wasn't really helping him. He was so frustrated that his sugars were so high all the time. He just completely stopped checking his sugars because he didn't know what to do about it. And when we went through and did a medication reconciliation, we found that his medications for diabetes were glipizide and metformin. And he had a couple other medications as well, including simvastatin for cholesterol control. So our initial intervention for this patient was really to focus on education. We got him the right glucometer that was covered by his plan. We helped him learn how to use it, understand why he was testing and what to do with certain numbers. We went through a thorough medication reconciliation with him, got him a medication list with why he's taking his medications, when to take it. And the step further beyond that to help with adherence, we helped him start off with a pill box. Because he was so disorganized to begin with, we started off by filling the pill box for him and having him come back on a weekly basis and check his adherence. And once his sugar started coming down and he started feeling better, we were able to transfer that management part to him and taught him to use the pill box so that he could take over and do that himself and become more independent. So after weekly visits and getting him on track, he started to feel much better. At this point, there's no change in medication. He started going back to the gym, sugars much better controlled, actually started having hypoglycemia, which is low sugar. because he was doing so well, and we were able to back down on his glipizide. He also no longer had the frequent urination, so we talked to his physician about stopping his Vesicare, so one less medication. And because he had been doing so well and we wanted to give him some positive reinforcement about all of his improvement, we checked an A1C and found that it had come down to 7.7 in that short amount of time. And then as an added bonus, because he was now taking his cholesterol medication on a daily basis, his LDL had improved to under 100. So as you can see, these are very significant changes for this patient from baseline. And I think even more noteworthy is that since the time that we first saw him 2 years ago, he's been able to maintain his A1C at goal. I'd love to talk about each and every one of our patients because they all have wonderful stories, but I don't have enough time today. So before I go into just general results for all of our patients, I wanted to give you an idea of what we're looking at and what we're focusing on. In addition to hemoglobin A1C under 8, we're looking at all the optimal diabetes care measures. So we want our patients to get blood pressure under 140/90, LDL under 100, and annual nephropathy screening. And we focus on these measures because our PCPs are incentivized to achieve these measures for their diabetes patients. So now taking a look at our second quarter 2014 results compared to the baseline. And this is for our 275 patients that we currently manage in our program. And when we average, the average initial A1C when our patients come in is around 10. So for patients with hemoglobin A1C less than 9, we're at 82%, up from a baseline of 30%. And for A1C under 8, we're at 63%. For blood pressure under 140/90, we're at 92%. For LDL under 100, 77%. And annual nephropathy screening, we're at almost 90%. And then at last check, we had about 50% of our patients that have achieved all 4 of these measures, the optimal diabetes care measures. So although we tend to focus on the numerical results for our program, we also recognize that, as mentioned before by Dr. Tsay, that the patient buy-in is really important and we want them to see value in our program as well. And so we do survey our patients, and here's a snapshot of our most recent results. So averaging out from the team, we have an overall of 4.6 out of 5. And, we're proud of these results, but of course we're always striving to get to that 5 and improve any way we can. So now on to my polling question. And this is thinking back to one of the first presenters. How many people in the U.S. with diabetes are undiagnosed? Okay, 61%, and that's good listening. All right. I like this slide because I think it's a good transition to the next part of the next speaker, who's our medical social worker, Sigol Phillipson. She's going to be addressing the emotional health side of diabetes through motivational interviewing.
Why are you truly here today? Learning what scares them the most about diabetes and letting them know that they ultimately can control this. We are here as their support. We're like the 4 tires on the car. But ultimately at night, they're the ones driving this. I provided PHQ-9. I'm not sure how many would be familiar with this. It's a screening tool that is given to assess for depression. However, I use this once again as a guide only because there's a lot of cultural subtleties with this. And a lot of the symptoms that are on that are related to their uncontrolled sugars at the time. It's interesting, a lot of times in the initial diagnosis or when they're unsure that they even had diabetes, the spouses will be like, he has just not been the same, or she just doesn't want to do the things, she's just feeling a little down, and there's no history of depression or any recent life events or psychosocial stressors. It's really truly because of their elevated blood glucose sugars. As Dr. March had mentioned, we do what it takes to stay in touch with the patients. I do follow-ups, whether it's telephonically, email, or when they come back in the clinic. And of course, happy birthday calls. My singing isn't the best, but they appreciate the call. The biggest thing also is that I wanted them to continually reinforce the big C's. Consistency, commitment, and confidence. If they believe in themselves that they can control this, because we know they can. We believe in them, we need them to believe in themselves. So behind the scenes also I do case management. So I open up these patients into our internal system, AE, to see what's going on with the patients, not just with the diabetes and the referrals, but to monitor any referral activities, any emergency visits, hospitalizations, etc. Ensure that they're adherent to the treatment plan, and also the referrals that have in place, not just by us, but their primary care physicians and or other specialists. I additionally communicate with the providers and specialists, obtain progress notes as needed, share with the team so that we're all on the same page with our care and care coordination. Okay, so as you see that this program truly has been rewarding and impactful for many of our patients and their family members and primary care physicians. Let's just pick a quote. I felt so overwhelmed by my diabetes requirements, I almost gave up on hope of managing it. I felt it couldn't be done. They active felt it could be and kindly are teaching me how. So in closing, this quote speaks loudly of our, oh, just kidding, we're on a polling. So polling is open. Which of the following statements are true? Depression causes diabetes, diabetes causes depression, diabetes and depression can be related, diabetes and diabetes are not related. I think it meant diabetes and depression are not related. Oh, excellent, 96%. We're doing good. So as I was saying, that this last slide that I'm going to show is really what our program speaks so loudly. Tell me and I forget. Teach me and I remember. Involve me and I learn. Thank you.
I told you these are dedicated people. Before we introduce our patient guests, I just want to remind you that we do have a website that you can go onto and actually see another patient of ours was kind enough to put on video, on film, how he felt about our program. So that is the website, and if you go to www.gmpweb.com and hit stories, you can actually see a few of our patients that are here. So at this time, I actually would love to have Dr. March come up and introduce our patient guest here. So a little bit behind the stories.
So our first guest VIP patient speaker today is Pastor Michael Whitfield. So I'd like to welcome him to come up and share some of his experience.
How's everybody doing? Amen. If I say amen, y'all forgive me. I'm a pastor of a church. Believe it or not, I preach in front of thousands of people, and you wouldn't believe that I'm shy. I'm very, very shy when I do this. But anyway, I would like to tell you my story if you just have a minute and want you to think about it could have been you, could have been your family, your loved one. In order to give you the feeling of my story, if you don't mind, I would like for my partner, my best friend to come up, my wife, Twyla, to come up, if she don't mind. Amen. Come on, you can make some noise here. There you go. There you go. And the reason why I asked her to come up, because I found out when you're going through something, you shouldn't have to go through it alone. You should have somebody that cares for you. And I thank God for her. First of all, I want to give honor to my God, not to offend nobody. The second, I want to give honor to the committee and to the staff and to my doctor, who've been so kind. And third, I would like to thank you for coming and for allowing me to share my story. I want to start off saying about 8 to 10 years ago, I lost one of my best friends. Somebody that been there for me every time I was sick, every time I mess up in school, and every time I was in the hospital, my mother was there. But there was one time I couldn't not be there for her. My mother was diagnosed being a diabetic. She stumped her foot and she didn't tell nobody. We never realized that the insulin, taking your blood sample, I never realized that was important. We never thought about it. I got 6 brothers and 6 sisters. We never thought about it. So we wasn't educated. Now, in the book of Hosea, chapter 4, verse 6, God said to Hosea, the people perish for the lack of knowledge. Today in this room and with my doctor, I gained so much knowledge that I can beat this thing. I often said, diabetes don't have me. Because if diabetes got me, it got control of my body. So I said, I got the diabetes because I got the control. As long as I have a good doctor, follow their advice, as long as I take my medicine, exercise, and eat right, I'm in control. So diabetes doesn't have me. I have it. I'd like to tell you, I'm a pastor of a church in the great city of Compton, California. I've been married to this wonderful woman for 3 years. And 3 months after that, 3.5 years, she got that right. 3 months, 3 months after that, I became a pastor of this great church. And we got all these kids in the church. I'm not talking about babies, I'm talking about grown-ups. Some big, some small, and some of them got bad eating habits. When I first came pastor of the church, we were serving breakfast, and I realized their breakfast was donuts and coffee and hot chocolate to all these little kids. And most of members of my church are diabetic or they have high blood pressure. So the first thing I did, I changed the eating habits to healthy food, oatmeal, brown bread, boiled eggs, apples, oranges. And people in the church start feeling better. So that's why I say if we don't give them the knowledge, then we all suffer. And third, Monday, April the 3rd is Monday, April the 30th. I call that Monday. It was my day that I woke up that morning to go to work. Got up and I prayed like I do every morning. Put on my clothes, kissed my wife goodbye. But she realized I wasn't feeling well. I said, no, I can make it today. Do you believe just for me to climb 5 steps, I had to stop and look at it, and I had to pray. God, I need some help to climb. I'm 50 years old. 5 steps. I didn't know what was wrong. For 2.5 months, I went to work sick because no one told me that I was a diabetic. Nobody. So I didn't know the symptoms. I didn't know what was going on. I went to church one Tuesday night. My spiritual son, he's 10 years old. Little kid that I got off the park, a little young kid. And he came to me, he said, Pastor, are you feeling okay? I said, why, son? He said, you don't look well. Your eyes is going to the back of your head. And that scared me for a 10-year-old kid to tell me this because he was telling the truth. I saw it in the mirror, but I just acted like it didn't exist. I went to work. My coworker told me the same thing. So April the 3rd is my day because when I went to work, I went there to give my employee the best I can do, sick or whatever. But something happened. My wife came, my best friend. She said, you got to go to the doctor today. You got to go now. I called the doctors, and they waiting on you. So I clock out. I went to the doctor, and Dr. Kristen, they saw me, and they couldn't get a reading on my finger. They couldn't get it. They couldn't get my level, my sugar level. And they said, you got to go to the hospital. I told my wife to drive me. Because I said, they're not going to keep me. It's nothing that a Tylenol can't cure. I got there. They kept me overnight. I didn't realize I was as bad off as I was. I didn't realize I was sick. Only because from the lack of knowledge. Now, the question will ask this. Would I tell somebody else? Of course. I tell people in my church all the time, go to the doctor, get checked out. As of right now we speak, I'm having a medical clinic to come by there to test the people's blood, test their blood pressure. Because the lack of knowledge, people don't have to die. In my closing, I want to say thank you. Thank you to the doctors and to those that invested their time, that stay up late at night. You never knew who I was. You never knew your job was so important. When you sat there and you wanted to give up, you never realized it. I want to thank you. My wife wants to thank you because she's not a widow. Angela, Michelle, Max, my children, I have 4 grandchildren. They want to thank you because I'm still alive. My church family, they want to thank you guys because I'm still alive. So at the end of my conversation, I want to tell my doctor, thank you. Tell the staff, thank you. And tell you guys, thank you.
Thank you. My name is Margot Bennett, and I'm a patient of Dr. Marsh and many others, and my regular doctor, Dr. O'Valley. And Dr. O'Valley took my blood test one day and looked at it and said, I want to send you and get you a A1C. I said, what's that? So anyway, I got that, and on February 10th, 2014, my A1C was 8.0, and he said, I'm sending you to a group of, it would be the care of diabetes and the program that you're here for. And anyway, on June 16th, 2014, my A1C was 6.5. And when I went back to my doctor, regular doctor, he said, whatever you're doing, keep it up. But he didn't know about all these programs I was going to. I don't think the doctor knew about all this wonderful support group that we now have. A little bit about me. This is my brother David Lumbert, and we live together in Newport Beach, and we both are retired and on Social Security. We have hobbies of ham radio. We are CERT volunteers. We do square dancing, and we are a caregiver for an 86-year-old veteran, and he lives up here in Alhambra, so we knew where this was. We come up here quite often. And we're members of the 24-hour fitness program because United Healthcare does have the program that you can go and have a gym membership, and all you have to do is take advantage of it, which we were not doing like we should on a regular basis. And what I was saying that was my April Fool's joke, because April 4th was the first day that I went to the diabetes program, and that's when they showed me all this information that I've got to straighten up and do something before I'm 0.9, 10, or whatever. But as far as activities, we were quite active, so I could not understand why I had diabetes. I didn't believe it, or I thought, well, it's just that day that it was high. I wasn't really depressed or all of those things that people probably go through when they say you have diabetes. So then my brother Dave, he had something to say about it.
Even though I've never been diagnosed with diabetes, I've had high triglyceride count in the 400s and 450s. And my doctor told me that what happens is with high triglycerides, that then turns into cholesterol, and we all know what happens when you get too much cholesterol in your system. It creates havoc. So he gave me a challenge last December to get off of that. And so I did that. And so I lost about 15 pounds, and then I just kind of stagnated along the way with, I no longer drank Coca-Cola for sure, and anyway, I was just kind of stagnated with that weight. And then when Margot was diagnosed with her type 2 diabetes, and then we met with Dr. Marsh, I went along with her because we need a support system. And I was a perfect candidate for that support system because I needed what she had to give to Margot. So I listened very carefully, and then Margot and I came together and we decided on how to change our lifestyle, and we will continue that from now on, to no longer consume massive amounts of sugar or carbohydrates. I got to look at my notes here. As it is now, I agreed to the challenge, and I have lost 25 pounds. Okay, maybe that's not what some other people have, but that's quite a bit, and I pulled in my belt about 4 notches now. Okay, so I feel much better. Okay, let's see. Oh, and I'm going to let Margot speak now.
What we did was we started a log. And this log that we started was weight. I took mine every morning. April 26th was the first time, and I was 183.2 pounds.
I was 214.8.
And then this morning after vacation, a whole week of vacation, and we watched ourselves very carefully over the vacation, I was down to 167.2. So I've made great progress, and I lost 2 pounds on vacation.
And I'm now, and I'm 207.6. So I've lost almost 7 pounds on the program, and thank you for that.
And then we also took our blood pressure every day and in the morning, and we started that June 10th. We bought a nice blood pressure machine, and this morning I took it again, but during vacation we did not take our readings. I didn't even take the glucose, and I've been taking the glucose. I've got my chart. I take it in the morning and at night. And our activities, what we did was when we became ham radio operators, we're still active in that. We passed our exam, and we also went through the CERT program, which keeps us active. And we do square dancing. We've got lots of square dancing, fun things we do with fun people. So we were never depressed. We just couldn't understand how this diabetes came about. We still don't understand that, but here we are, and we're having a wonderful time with all of you.
We also visit the 24-hour fitness on a regular basis, and that seems to be a lot of fun also. And we find the energy to do that now where we didn't have the energy before.
We read newspaper articles, snack food companies. We went to the movie Fed Up. If you're not familiar with that, did you go to that movie? I think we tried to get someone to go to that from the program, and Bill Clinton had his picture in the paper about the Fed Up movie. You're welcome to look at all these things or make copies of them. I saved something on weight right after New Year's Eve, the weight programs that come out in the newspaper. Study, diabetic care costs more, from the Orange County Register, and this was May 16th, 2014. Then we have all these meal planning handouts that we've gotten from all of you, and when we went to the dietitian and we talked about labels, we'd already gone to the store and spent several hours just looking and reading what we'd been eating, what we could eat, and gosh, I think I threw lots of things away.
We were quite shocked when we looked at the labels and we saw the massive amounts of sugar and carbohydrates that was in the food that not only we were eating, but everyone else was eating. And there basically isn't many foods that are left that doesn't have all of that carbohydrates and sugar in it. So that made it even more difficult for us to decide on how to make our life changes.
We also went to fast food stores, fast food restaurants, and got their nutrition handouts, and we studied that, and there's only 1 or 2 items we can eat on there. So, and we're having a real good time doing all this, and what I plan to do next is organize it, get a loose leaf binder, start punching holes, and helping myself keep track of all this and reread it because we forget.
One of the things that we've decided that we can eat anything, anytime we want to, as long as it falls within the criterias of 45, 15, 45, 15, and 45. And before 6 o'clock in the evening. And that's really an important issue because with our weight thing, we've tested and we've eaten after 6 o'clock, and we find that we will gain weight. Even though we follow the rules, we will gain weight, and that is a real issue for us.
We want to thank all of you, too, for having us here. We've really enjoyed this, and thank you so much for all of your help in... Oh, you wanted to say one?
There was one other issue that Dr. March wants us to talk about. Would we recommend this program to other people? We talk to people constantly about this, and it is amazing how many people do not want to hear that there's a possibility that they could get diabetes. In my case, I'm going to take and beat it down before it ever gets to me. Okay, Margot?
Thank you so much.